Hi folks, good day again and welcome to this video lecture on informed consent in clinical practice, which is meant to complement the existing face-to-face lecture on informed consent that you've had already. So some basic principles, we went through why consent is important, and it's mainly important because it's a legal requirement. It has very, very severe legal implications. And consent basically allows a medical professional to proceed with interventions that would otherwise constitute trespass, battery, or assault. And we went through very briefly what was the difference between assault and battery in the lecture. Assault is a threat of physical violence, and battery is when the threat has been carried out and the actual physical violence has occurred. Um, it might seem a bit off that doctors are this is the only legal recourse that a patient has if the doctor does something without the patient's consent, right? So any procedure that the doctor performs on the patient, however minor, putting up an intravenous line, doing a lumbar puncture, uh, excising a mole, excising a lump and bump, a simple lipoma, all these things, no matter how trivial, or intervention, or considered from a legal point of view, they're considered interventions, right? And you can be sued for assault and battery or charged with assault and battery, indeed, in worst case scenario, if you do something without patient consent, okay? So valid consent is composed of three elements. It's informed, and this is what the lecture is about, to go into some detail what informed consent means. It's voluntary, and it is given. So if somebody gives you their consent under duress, it's not considered voluntary, so it's not proper consent. And it is thirdly, it is given by somebody deemed competent. Um, and we could say competent, we meant somebody with mental capacity, right? So the scope of valid consent is not unlimited. It only pertains to those interventions to which consent was specifically given, and any doctor acting beyond those parameters can be found guilty of battery. So just because the patient gives you consent to, let's say, do a bilateral tubal ligation, in common parlance, tying off the tubes, it doesn't give you the consent to go and do a hysterectomy, take out a uterus, right? She can be sued for battery afterwards. So we went through this, right? What's the problem? Of course, you could be charged for assault and battery, and of course, you're violating patients' human rights, okay? And the only justification for treating an adult patient against his or her wishes is when he lacks capacity or using the principle of best interest and emergency. So informed consent and consent forms. Now, I know a lot of you as medical students will just say, well, I have a consent form, and that's good enough, but it's not, right? Read the last line. Consent forms are not a blanket defense for explaining complications or getting informed consent, right? So just because you sign a consent form doesn't mean that you've actually gotten informed consent from the patient, right? Informed consent means that you must have some sort of meaningful dialogue which is tailored to the individual patient's needs. So part of a doctor's duty of care to the patient includes a duty to give him or her careful advice and sufficient information upon which to reach a rational decision whether to accept or reject treatment. And all patients have the right to be involved in decisions about their treatment and care and be supported to make informed decisions if they are able. And I just want to emphasize, and be supported. So sometimes the patients may refuse consent, or they may not agree with the plan that you're presenting to them. Don't take offense. It's not personal. Patients are human. They have their own rationale. So we as medical professionals, it's incumbent on us to support them when they do make that decision. So decision making is an ongoing process focused on meaningful dialogue. So just because you have one single conversation with the patient, doesn't mean you have informed consent either, right? Sometimes the patient may want to ask some more. They might go away and have some more questions, right? They might want to come back and ask you some more advice about what to do, how to proceed, right? So it is an ongoing process. All patients have the right to be listened to and to be given the information they need to make a decision and the time and support they need to understand that decision. Doctors must try to find out what matters to patients so they can share relevant information about the benefits and harms of proposed options and reasonable alternatives, including the option to take no action or to refuse to go along with the doctor's plan. And doctors must start from the presumption that all adult patients have capacity to make decisions about their treatment and care. So the choice of treatment or care for patients who lack capacity must be of overall benefit to them, and decisions should be made in consultation with those who are close to them or advocating for them. But that a proviso there that depends on who is present when the patient comes into the hospital. Okay, sometimes there is no family around, and you as the medical professional are tasked with acting in the patient's best interest. So when we say dialogue, what do we mean, right? So the purpose of the dialogue is not just talking to the patient, right? It's A, to help the patient understand their role in the process and their right to choose whether or not to have treatment or care, to make sure the patient has the opportunity to consider relevant information that might influence their choice between available options, and to try and reach a shared understanding, and I want to emphasize that word shared understanding of the expectations and limitations of the available options. So in terms of the information required to meet the standard for informed consent, some information patients want or need might include diagnosis and prognosis of the disease, uncertainties about this diagnosis and prognosis, options for treating or managing the condition, including the option to take no action, the nature of each option, what will be involved, and the desired outcome, and the potential benefits, risks of harm, uncertainties about and likelihood of success for the options, including the option to take no option. But this is just some of the information that the patient may want or need, right? When you're giving the information, try to be objective. Don't try to sway the patient to one management plan or the other. Don't rely on assumptions. Like, don't assume that the patient doesn't understand your medical terminology. Um, the patient may want to know who is being involved in his or her care, and don't withhold any information just because you think it might upset the patient, especially in a setting of breaking bad news. So information, again, finding out what matters to the patient, encourage the patient to ask questions. Again, don't assume that the patient, don't make assumptions about the patient's education level and assume that they may not have any questions at all. Find out what matters to the patient about their health. What are the patient's values, priorities, concerns, preferences, and what risks are they prepared to take or not to take, as the case may be. When you're discussing benefits and harms, you must give patients clear, accurate, and up-to-date information based on the best available evidence about the potential benefits and risks of harm of each option, including the option to take no action. It's not reasonable to just kind of sit down and explain every single complication of every single procedure. In that case, you'd be there forever, right? That's not what informed consent is about. And each patient is different. Each procedure that the patient is having is different. Each management plan, each disease that the patient has is different. Each management plan that the patient has is different. So you should tailor the discussion to each individual patient. So that doesn't mean, informed consent doesn't mean you sitting on there for hours and hours explaining every single complication of every single procedure. That's not what informed consent is, right? Going back to benefits and harms again, discuss recognized risks of harm that you believe anyone in the patient's position would want to know. The effect of the patient's individual clinical circumstances on the probability of a benefit or harm occurring. And if you know the patient's medical history, you know some of what you need to share already, but the dialogue could review more. Any risk of harm and potential benefits that the patient would consider significant for any reason. And this could be out of the box, out of your medical box, right? And these will be reviewed during your discussion with the patient about what matters to them. And any expected harms, including common side effects and what to do if they occur. So in terms of supporting the patient's decision making, share it in a place and at a time when they are most likely to understand and retain it. Sometimes it's difficult to do this in a public health setting when you're very busy and there's an emergency situation, but try to do it as much as possible. Anticipate whether they are likely to find any of it distressing, and if so, be considerate when sharing it. Accommodate a patient's wishes if they would like anyone else, a relative, a partner, a friend, a carer, or advocate to be involved in any discussions about their care. And we have a lot of Venezuelans in Trinidad. Use an interpreter or translation service if they have difficulty understanding spoken English. So just some clinical examples. In 1994, Smith brought a claim. He was 28 years old. against a surgeon who had not warned of the risk of impotence post-rectal surgery. And judgment was found for the patient on the basis that even though there was a responsible body of medical opinion that would not have warned of this complication, failure to warn the patient of a risk of such importance to him was neither reasonable nor responsible. So if we go back to the slides, recognize risks of harm. When you're discussing benefits and harm, discuss recognized risks of harm that you believe anyone in the patient's position would want to know. And of course, any 28-year-old man would want to know whether he'll be rendered impotent as a result of the surgery, right? So that is an example of how you should tailor the discussion to the patient, right? And the judge was very, very clear. Failure to warn this 28-year-old man of the risk of impotence was neither reasonable nor responsible on the part of the physician. So in 2004, a patient sustained cauda syndrome post-lumbar spine surgery and claimed that the neurosurgeon failed to warn her of a 1 to 2% risk of cauda syndrome occurring, and the surgeon was held liable. So if a 1 to 2% risk might not seem a big deal to the surgeon, but it's a big deal to the patient, right? So it's entirely possible that had the patient been told about this one seemingly marginal risk, she wouldn't have had the surgery, right? Now, this is the seminal case legal case that upheld informed consent, right? So this mother, Mrs. Montgomery, in 2013, delivered a baby. The baby sustained shoulder dystocia during delivery, which led to brachial plexus injury, hypoxic brain damage, and subsequent cerebral palsy. And she claimed that she was not warned by her obstetrician of the 9 to 10% risk of shoulder dystocia. Now, again, it might seem like a trivial risk to experienced obstetrician, but that small risk, that trivial risk to the surgeon may be of great risk to the patient, right? And again, had she been informed, she might not have gone for a natural delivery and gone for cesarean section instead. So again, judge's comments, while assessment of the risks and benefits of treatments is properly regarded as part of medical expertise, the decision whether these should be discussed with the patient is not purely a matter of professional judgment. So you must discuss it with the patient, okay? And further comments from the judges, in identifying the doctor's duty to disclose a material risk, the court stated that the starting point should be the needs, concerns, and circumstances of the individual patient. So again, getting informed consent, achieving informed consent is not just sitting down and explaining away every single complication. It must be tailored to the individual patient. And in this case, this patient, that small 9% risk of shoulder dystocia meant the world to her. And she would not have gone ahead with a natural delivery had she been informed of it, okay, and had it been discussed with her. So all through the lecture, the presentation, I've been mentioning that the patient has the option not to proceed with care or to refuse care. It comes down to refusal of consent and autonomy, and the principle of self-determination requires that respect must be given to the wishes of the patient, so that if an adult of sound mind refuses, however unreasonably, to consent to treatment or care by which his or her life would or might be prolonged, the doctors must give effect to his or her wishes, even though they do not consider it to be in his or her best interest to do so. Emergency situations are different. If the patient is unconscious, for example, after a road traffic accident or after a heart attack or a stroke, is incapable of giving consent, and there is no one available to give consent, physicians are protected by law if the medical procedure is considered to be reasonable and you are thinking of acting in the patient's best interests. Okay. So this brings us to the end of the lecture, Informed Consent in Clinical Practice, and I'll see you for a subsequent lecture. Okay, thanks for your attention as always.